Okay, thank you, Kuldeep Singh. So we can start. So the very first question was about a developmental stage of female, and it was given that Thilarchi has been attained, Pubarchi has been attained. Now, what will be the next step or next phase in the development of a female? So to remember the different steps, already though two has been given, that is Thilarchi, that is related to breast development, right? So this is Thilarchi. Then another is, which was given, was Pubarchi, that is growth of pubic hairs. Now after these two steps, there is rapid growth, what we call growth spurt, right? So there is a rapid acceleration in the growth, and that is known as growth spurt. And the last phase is the onset of menstruation, that is known as menarche. Clear? So this is the stage wise development in a female, and the question was about like what after pubarche. So after pubarche, the stage will be growth spurt. Clear? So these are the four stages in female: Thilarchi, pubarche, growth spurt, and menarche, right? So please remember these four phases, and the question was about like what after pubarche. So here your answer will be growth spurt. Clear? Thilarchi, pubarche, growth spurt, and menarche. Either you can remember the sequence or you can make your own mnemonic, but this is the stage wise developmental steps. Now another question was about oral contraceptive pills, and the question was like oral contraceptive pills are not protective against which carcinoma? Clear? So oral contraceptive pills are not protective against which tumor or development of which carcinoma? Now here remember three, right? So one is ovarian, right? So one is ovarian, second is endometrial. Okay, so the second one is endometrial, and the third one is colorectal. Clear? So the third one is colorectal, or you can say colon carcinoma. Clear? So please remember these three tumors. So ovarian, endometrial, and colorectal. Clear? So these are the three tumors against which oral contraceptives pills are protective. Apart from this, they are also protective against other entities like endometriosis and other entities. But in terms of tumors, they protect against ovarian, endometrial, and colorectal. And here they do not have any protection against the development of cervical cancer, right? So they do not offer any protection against the development of cervical cancer. Okay, so please remember this a question which has been repeated over the years. Then there was a question about the percentage of the fixative which is used in pap smear, right? So what fixative has to be used in what percentage for pap smear? And this is usually 95% of ethyl alcohol, right? So this is usually 95% ethyl alcohol. So I think all of you must be knowing that we do pap smear as a screening test. Clear? So this is a screening test, and we just want to detect cervical cancer at the earliest, right? So this is the use of pap smear. And in the pap smear, we use an Ayers spatula and we take out the cells, and then it has to be fixed. So the fixative used here is 95% ethyl alcohol, and the basic purpose of this fixative is to just make sure that the cells they don't dry up. So in a pap smear, the fixative is used to preserve the collected cells and to prevent them from drying out. So that is very important. The use of fixative is to prevent drying of the cells before they are stained and analyzed. So the cells have to be preserved, and just to make sure that they don't dry up, right? So here the most commonly used fixative in pap smear is 95% ethyl alcohol. So again I repeat, 95% ethyl alcohol, and this is again used to immediately fix the smear once it is prepared, and it just makes sure that cellular details are maintained. And once the cellular details are maintained, then obviously we will be able to make a accurate diagnosis, right? So in pap smear, which is done as a screening test for cervical carcinoma, the fixative used is 95% ethyl alcohol, right? Then another condition was an image based question, and this is, if I say, one of the easiest condition to identify, because what we see here, obviously we can see hairs, clear? Then we can see dental tissue, teeth. So if you have any ovarian condition which is having different type of components like hair, teeth, then this is an example of teratoma, which is also known as a dermoid cyst. So this is an ovarian teratoma, very easy to identify provided you know the fact that it contains hairs and dental tissue as well. So the moment you see the teeth or you see hairs, don't hesitate to mark it as teratoma or dermoid cyst, right? So teratoma is a germ cell tumor. Okay, so it is a type of germ cell tumor that contains various types of tissues. It can be hair, it can be teeth, it can be bone, or it can be even muscle, right? So you see so many types of tissues. So the moment you have this kind of presentation, don't hesitate to mark it as teratoma. And yes, these are commoner in ovary, testicles, but it can occur anywhere, right? So this is ovarian teratoma, also known as dermoid cyst. Clear? So teratoma or dermoid cyst, the easiest of all conditions in which we are given gross appearance. So the moment you see hairs, teeth, straight away teratoma. Now absolute contraindication for intrauterine contraceptive device, like in which condition we should never give or we should never use intrauterine contraceptive device as a contraceptive method. So again, the list is very long and it is up to you how many conditions you can remember, but the option which was the actual answer in the examination was unexplained vaginal bleeding. Okay, so this was the answer in question paper in FMG exam. So that was the answer. Unexplained means we don't know what is the cause of this bleeding, right? So unexplained vaginal bleeding. So in such cases, don't insert intrauterine contraceptive device as a contraceptive method, right? So this is one important condition here. Now apart from this, there are a few more conditions which you should know as an absolute contraindication for IUCD use. One is, of course, current pregnancy. If there is pregnancy, there is no point in using IUCD. Then if there is pelvic inflammatory disease, what you write as PID, right? So in acute PID, don't use IUCD, right? Obviously, if there is any infection like puerperal sepsis, don't use IUCD. Then if there is any distortion of the uterine cavity, again, if the normal anatomy of the uterus is distorted, the moment you insert the IUCD, it might lead to some injury or some complications. So don't use IUCD in such a case. So these are few common contraindications which you should remember. So current pregnancy, right? This is one. PID, sepsis, puerperal sepsis, obviously unexplained vaginal bleed, and altered uterine anatomy. So just remember at least these 6. Now moving forward to another question, and here a lady presented with amenorrhea, right? So there is no menstruation, amenorrhea, clear? So there is no menstruation, and there is a past history of multiple dilatation and curettage. So there has been multiple episodes where there was DNC which was done inside the uterine cavity. So dilatation and curettage. And now what happens whenever curettage is done, there is possibility of, you say, additions, intrauterine. So dilatation and curettage, that is DNC, right? So one of the complication which can come out of this is intrauterine additions, right? So within the uterine cavity, clear? So there are additions within the uterine cavity, and this condition is known as Asherman's syndrome. So this condition is known as Asherman's syndrome, right? So intrauterine additions, these are known as, this is known as Asherman's syndrome, and yes, this is principally seen after dilatation and curettage. So here in the image we can see additions within the uterine cavity, and that what leads to infertility, right? So lady with amenorrhea, infertility, and multiple DNC, always think of intrauterine additions, that is Asherman's syndrome. Now there was one question about co-testing. Now this is a new question, co-testing. Now as the name suggests, co means together. So here we are using two tests together, right? So we are using two tests together, co-testing. Now this is especially used for carcinoma cervix. Okay, so carcinoma cervix, and I think we have just discussed one question about fixative in pap smear for carcinoma cervix. So one of the tests in co-testing is of course pap smear. Clear? One of the component in co-testing for carcinoma cervix is of course the pap smear. Now if you know the causative agent of carcinoma cervix, you can think of the another test which is done here. So the causative agent for carcinoma cervix is human papilloma virus 16, 18, 31, 33 and many, right? So human papilloma virus. So what we do some check about human papilloma virus as well. So if in a suspected case of carcinoma cervix, if you do pap smear and human papilloma virus detection simultaneously, that test is known as, that is co-testing. Clear? Co means together. So we are doing two tests together. So co-testing for cervical cancer involves doing pap smear and also human papilloma virus test simultaneously on the sample, on the same cell sample, right? So we are doing two tests. One is of course pap smear and the second is human papilloma virus test, and we know that this is the causative agent. So we are looking for the presence of the causative agent as well, along with the cellular changes coming out in cervical cancer. So this is co-testing. Now this approach is more effective in detecting cervical cancer and precancerous changes than either test alone. Obviously, if you are doing only one test, the outcome or the chances of success are less. But if you apply two tests, obviously we are increasing the output of the test, and we are getting higher chances of detecting the condition at an early stage. So co-testing, and it is recommended in the age group of 30 to 65 years, and it can be done every 5 years if both comes out to be negative. So we can repeat the test every 5 years if the test is negative, if both the tests are negative every time. So just at an interval of 5 years. So this is co-testing, and this aims to detect cervical cancer at an early stage. Is that clear? Co-testing. Now there was one very interesting question, and here a hysterosalpingogram was given. So hystero, then salpingo, right? So hystero salpingogram. Now I think most of you must understand hystero means uterus, salpingo means fallopian tube. Clear? So in this is actually a dye based test, and here what we are doing, we are injecting the dye and we are checking about its progression through the uterus, fallopian tubes, and whether it is coming out through the ostium or not, right? So this is hysterosalpingogram, and it actually checks the anatomy or the patency of the fallopian tubes as well. So now coming to the image proper, what we can see here. So what we can see here, this is uterine cavity. Then here we can see the fallopian tube. And suppose this is the right side, but what about left side? In left side we are seeing nothing, right? So we can't see any uterine cavity, or we can't see any fallopian tube as such. So it means there is uterine cavity and the fallopian tube only on one side, and if there is uterine cavity only on one half or one side, we call it unicornuate uterus. So we will call it unicornuate uterus. We can see only one half of the uterine cavity and the fallopian tube, right? So this is unicornuate uterus. Cornua means horn, and uni is of course one. So we can see only one side, and that is the right side here. Now this is the condition which we can diagnose from the given hysterosalpingogram. Now the question is about the embryological basis. Now you have to tell why this condition has developed. Why this condition has developed. So again, to understand this, you have to go to the embryology of uterus, right? So you must know what is that structure which is giving rise to uterus. So that is actually paramesonephric duct. So this is paramesonephric duct, and this is also known as Mullerian duct. So paramesonephric duct. Now what happens? The paramesonephric duct of both sides, right side and the left side, will fuse together and it will form the entire uterus. Now if there is no paramesonephric side, paramesonephric duct on one side, obviously that side of uterus won't develop. So this is the case here. There is no development of the left side of uterus, and this is because there is no paramesonephric duct on the left side. So the embryological basis of unicornuate uterus is that there is no left-sided paramesonephric duct. Clear? So a unicornuate uterus is a congenital uterine malformation which develops when one of the two Mullerian duct, and we know what is Mullerian duct, it is nothing except paramesonephric duct. Clear? So when there is failure of development of paramesonephric duct, the corresponding half of the uterus will not be formed. So a unicornuate uterus is a congenital malformation which develops when one of the two Mullerian ducts fails to develop during the fetal development. And when the two sides will fuse, so suppose if this is the right side Mullerian duct and when the left side Mullerian duct, like this, so this is left side Mullerian duct, when they will fuse together they will form the uterus proper, something like this. Clear? So if there is, say in this particular case, there is no Mullerian duct, so what is happening on the left side? So on the left side you don't see any outline of uterus. So what you can see, the uterus is something like this here, because this is not giving any contribution. So this is known as unicornuate uterus. And if someone asks you what is the embryological basis of unicornuate uterus, you will say that the Mullerian duct or the paramesonephric duct of the side on which we don't see any impression is absent. Clear? Again I am repeating, absent. Right? So absent Mullerian duct will give rise to unicornuate uterus. The next question, a 32 years old lady who is para 2 and live children's 2 is having recurrent endometriosis. So she is having recurrent endometriosis. Tubal ligation has been already done. Now how you will manage this case? So para 2 means she was having a pregnancy 2 times and both the children are living. And endometriosis means functioning endometrium but outside uterus, because normally we know that it is present within the uterus, but here the endometrium is present outside uterus and therefore the patient will classically presents with dysmenorrhea. Dysmenorrhea is painful menstruation. So this is a classical presentation, right? Now what, and one of the commonest site is of course ovary. So if you write about most common site, it is ovary, though it can be present anywhere in the pelvic cavity. Okay, so this is endometriosis. Now the lady is having the problem again and again. So what we need to do, and it seems the lady has already completed the family size, so better we can remove the uterus. But in this particular case, along with uterus, we have to remove the fallopian tube and the ovaries as well. So that surgery is known as hysterectomy, that is uterus removal. Then bilateral, clear, means both sides. So bilateral salpingo, that is fallopian tube. Oophorectomy, that is ovaries. Ectomy is surgical removal. So this surgery we have to do in a case of recurrent endometriosis. So it's a radical approach to treat endometriosis, where we remove the uterus, both the fallopian tubes and the ovaries also, because we know that ovaries, they release estrogen, which is the prime reason for this condition. So if we remove ovaries, we will remove the source of estrogen as well, because this estrogen is responsible for the growth of endometriotic tissue, right? So remove ovaries. So this is, if ovaries are removed, it means no estrogen, so there is no growth of endometriosis. Clear? So this is the surgery for recurrent endometriosis. Hysterectomy plus bilateral. So bilateral means both sides. So remove both sides fallopian tube, right? So this is fallopian tube and ovary. So this is the treatment for recurrent endometriosis in a lady who has already finished his family size, 2 living children. Now again, this is a repeated question. I think most of you must have done it right. A gynecoid patient is having infertility, right, and some degree of gynecomastia, and the karyotype is 47XXY, and gonadotropin levels are also high. So here the case is having infertility, that is inability to conceive. Then there is gynecoid built, but most importantly there is gynecomastia. So there is gynecomastia, that is enlargement of the breast in males, and if you look at the karyotype, this is 47XXY, and mainly if you find these two features, you can easily make a diagnosis of Klinefelter's syndrome, right? So this is Klinefelter's syndrome, and here the patient will be tall. So you see a tall male, with infertility, gynecoid features, gynecomastia, 47XXY, straight away you can mark the answer as Klinefelter syndrome. And this question has been repeated many number of times, so it's a repeated question. Now there was a new question, and that is MEC1, and this is in relation to oral contraceptive pills use. So MEC. Now what is this MEC? M means medical, E is eligibility, and C is criteria. And here they are specifically asking about the class 1, MEC1. Now this MEC, which is medical eligibility criteria, it tells us about the conditions where the OCPs can be used or not. So in 1, as such, there is no contraindication, and in 4 there are many contraindication and where we should not use. So suppose if the question was about MEC 4, now here OCPs are contraindicated. So here the OCPs are contraindicated. So the conditions like hypertension, okay, so say this is category 4. Diabetes mellitus plus vasculopathy, this is also category 4. So in such cases OCPs are contraindicated. This is contraindicated. Now HIV is class 1, and in class 1 there are no contraindications, so no contraindications, and hence we can use OCPs. Clear? So class 1 means there are no contraindications and the OCPs can be used freely. So MEC1 is, that is medical eligibility criteria. Now this refers to conditions where the contraceptive method can be used or not, and especially in relation to category 1 right? So in category 1 there are no restrictions, and again if the question is about category 4 there are restrictions. Okay, so this is MEC. Now these are the different categories for OCPs. Like in category 1, as I said, there are no contraindications. We can use OCPs in any circumstances. In 2 they can be generally used. In 3 they can use but not usually recommended. Okay, unless there is any other appropriate method which is available or not available. And in MEC 4, don't use OCPs. Clear? So in 4, don't use, like hypertension or diabetes mellitus. So in that condition, don't use OCPs. In category 1, like HIV, we can use easily. There is no contraindication. So the MEC, that is medical eligibility criteria, it is set of conditions in which we can use, we should not use, or we can use with precautions. So different conditions are being placed in different category, and based on that we will decide whether we should use OCPs or not. So in category 1 we can use it freely. In 4, do not use it. So this is the concept of MEC, that is medical eligibility criteria. So with this we end this session, and I'm very sure you might have enjoyed the session. And again, I'm very sorry for taking the session so late in the night. Anyway, thanks to all of you for joining me at such a late hours in the night. Thank you. God bless. Bye bye.